Welcome to Badger Talks Quick Picks, which brings exciting happenings, resources, and talent from your UW flagship campus to the people of Wisconsin and beyond, demonstrating the power of the Wisconsin idea, one connection at a time.
Welcome to today's Badger Talk. I'm James, professor and director of clinical training in the Department of Psychology. And today I want to talk about a new way to think about mental health and something that is very important to all of us. So imagine that you're going to a doctor's office and you've got chest pain. You'd expect some clear tests and maybe even a diagnosis at the end of the day, but in mental health, it works quite differently. It's not nearly as simple. In mental health, clinicians have to rely on a book. In this case, it's what's called the DSM-5 that lists hundreds of different disorders with checklists of symptoms that the clinicians have to then cross-check and observe to see whether or not the client meets criteria for. So it's based on observations and self-reports, not necessarily on biology. The core premise behind the DSM-5 for mental health is that DSM disorders are what are called categorical. You either have them or you don't. Each disorder has its own checklist of symptoms with its own presumed set of causes, and it even has its own presumed set of treatments. But this way of thinking, although it's been around for a long time, might be useful for insurance companies in communicating with other providers, but it also comes with a number of big problems. And here's the core issue that we want to contend with today. Are mental disorders really yay or nay conditions that you either have or you don't have? I think it's been pretty clear over the last half century of research that it's not that way at all. It's not like flipping a light switch, but rather more like a dimmer. And there are different shades and degrees to which we struggle with our mental health on any given day or even time. Let me give you some examples of some of the issues with this categorical way of thinking in mental health. Take, for example, attention deficit hyperactivity disorder, or ADHD. It is by far one of the most common disorders of childhood. Every 1 in 10 children are diagnosed with ADHD in the US today. To get this diagnosis, according to the DSM, you have to have either, or at least 6 out of the 9 symptoms in either the inattention category of the disorder or the hyperactivity impulsivity category. If you do some simple arithmetic, you'll see that that means that there are over 17,000 different ways that you can present with this particular disorder during childhood. That's 1,000 unique symptom combinations to meet diagnostic criteria for ADHD. So this begs the question. If you've met one kid with ADHD, then you've met one kid with ADHD. Not every child who has ADHD is necessarily going to look the same as the next child who's been diagnosed with ADHD. So how can we find a cause or even a treatment that works for all children who meet criteria for a disorder for which you have 17,000 different combinations to meet criteria for? There are other issues with this categorical way of thinking about mental disorders, and it's not just with ADHD. In this graph, you're looking at the prevalence rate of autism and how co-occurring different conditions might be along with having an autism disorder. And what we're seeing, and this is not just with autism, but especially true in the autism world, is that kids with autism tend to get diagnosed with many other disorders too. And so DSM disorders, including autism, tend to cluster or co-occur with many other disorders at the same time. So in this case, autistic kids are about 3 to 4 times more likely to also carry an ADHD diagnosis. They're about 2 or 3 times more likely to carry a depression or anxiety disorder diagnosis, and on and on. Depression and anxiety also tend to co-occur at rates that are far above what would be expected in the general population. And so this begs the question, if these conditions were truly distinct, then why did they cluster and co-occur so much? And yet there's more issues with this categorical way of thinking about mental health. Decades of costly and time-consuming neuroscience research has tried to find the signature brain profiles of these different disorders, as we believe that most mental disorders are sort of consequences of something disrupted or disturbed in the brain. But what have been the results of our research looking at brain profiles of individuals with ADHD or autism or schizophrenia? Almost nothing. For example, in this case, you're looking at brain profiles of many, many, many lines of research on ADHD with the idea of looking for a common ADHD profile brain so we could identify it and maybe even diagnose it based on MRI. And what we found based on meta-analytic evidence across all of these different research studies on ADHD brains is that there's only 2% overlap in terms of the ADHD brains across each other, which goes back to one of the earlier issues of the 17,000 different ways to meet criteria for ADHD. It makes sense that there aren't that many similarities even within the same disorder at the brain level. So this begs the question, is this a problem with our science and our technology? Or is this a problem perhaps with the way that we've been defining mental health disorders in the first place? Researchers today, I think, are now believing that the problem is with the definition itself. And this is based off of many, many decades of thinking and science and research that have led to this conclusion. We need a new framework, essentially in mental health, that isn't confined by man-made categories based on century-old theories that haven't been proven to be true. We also need a new framework for mental health that's driven by science and data. And more importantly, we need a new framework that reconceptualizes mental health as something that we all have and not just something that we either carry or don't carry at any given time, that we all have at various levels. So enter HiTOP, which stands for the Hierarchical Taxonomy of Psychopathology. This is a new mental health framework that's driven by the science and the data. It reimagines mental health from the ground up. And it basically takes all of the constituent parts of the DSM, all the symptoms and the checklists, all the hundreds and thousands of different ways that we can meet diagnostic criteria for these 300 different disorders that are currently categorized in the DSM. And it reorganizes all of these different parts into a broad spectrum of functioning that's not just part of a checklist, but something that we can all vary on at some point. HiTOP isn't just a concept or a novel idea. It's actually backed by empirical evidence across many hundreds of studies at this point, which have validated and replicated this idea that mental health is actually on a spectrum and not necessarily based on unique, discrete categories. So what is HiTOP? HiTOP basically reorganizes the 300 distinct disorders that are currently in the DSM-5, and it basically identifies a cluster in which all of these different 300 disorders tend to happen together. So we call those dimensions. There are 6 basic dimensions of mental health that the data have sort of driven us to converge on. So these are the 6 spectra of mental health as currently we know based on the data in HiTOP. Here's what they are. The first is what's called the internalizing dimension. This is representative of symptoms and traits like emotional distress, sadness, and fear. And some of the disorders that we might think about that map onto this dimension would be like, for example, depression and anxiety. There's also the somatoform dimension, which represents physical symptoms that don't have clear medical causes. This might be representative of things like somatic symptom disorder. Detachment, which is representative of symptoms like social withdrawal and lack of pleasure. And this might be representative of disorders like avoidant personality disorder. There's the thought dimension, which represents disruptions in thinking and perception. And some of the disorders that might represent this particular dimension are schizophrenia or psychosis. Then there's the disinhibited externalizing dimension, which it represents impulsivity and risk-taking. Disorders like ADHD and substance use disorder fall under this category. And then there's the antagonistic externalizing dimension, which represents aggression and hostility. So we have conduct disorder, antisocial traits. There's one other that I missed, which is detachment, social withdrawal, and lack of pleasure. And some of the disorders include schizoid personality disorder for that. One of the major advantages of HiTOP is its approach to patient care. So instead of telling a patient that they may or may not have depression, for example, based on where they score on a checklist or how they look at a given time, clinicians can instead ascertain a profile score across these broad dimensions in HiTOP, identifying which specific dimensions that patient might be struggling in at any given time. And as you can imagine, this helps tailor treatments to the person instead of the label that they carry. Another advantage is that it simplifies our treatment approaches to our patients. So instead of having to draw upon hundreds of different treatment manuals or drugs, treatments can instead focus on addressing the deficits or the issues representing those core 6 dimensions. So the future of HiTOP, or the future of mental health, rather, we believe is dimensional. It's data-driven, and it's designed to be focused on the patient rather than the label, rather than to fit people into these boxes. HiTOP is always evolving, and it's a growing movement. And if you'd like to learn more, please visit hitopsystem.org. Thank you very much for watching today's Badger Talk.